Maryland has more than 4,200 behavioral health beds spread across 440 licensed facilities. The physical capacity for statewide treatment exists, yet 87% of residents who need these services never receive them. This disconnect plays out in hospital emergency departments every day. Patients experiencing a psychiatric crisis are routinely boarded for hours, sometimes days, waiting for a social worker to secure an inpatient placement. The beds are out there. The bottleneck is a data logistics failure known as ghost inventory, a situation where physical capacity exists but is invisible to the people trying to dispatch patients. Consider the legacy infrastructure, the 211 bed board. Facilities manually update their availability just 3 times a day. In an emergency triage environment, a bed can be filled in 15 minutes. An 8-hour data gap means planners make decisions based on total information blackouts and wasting time calling facilities that reached capacity hours ago. Information latency of this magnitude paralyzes hospital throughput and strands the state's most vulnerable patients in waiting rooms. This failure is why a platform called MDAddiction.help was developed. It replaces the static directory model with an infrastructure-level dispatch utility. Looking at this dashboard, you see 4,272 beds actively tracked across the state using zero-knowledge filtering. The system enforces a strict 12-hour threshold. Facilities must update their census counts from a mobile device, or the platform flags their data as stale. This live tracking mechanism directly answers incoming legislative requirements. Under Senate Bill 870, Maryland now mandates near real-time tracking of adolescent hospital overstays and bed availability. But building a live behavioral health registry collides directly with another piece of state legislation, the Maryland Online Data Privacy Act. Taking effect in late 2025, this law establishes intense data minimization standards and explicitly bans the sale or non-consensual processing of sensitive consumer health information. Any entity controlling data for more than 35,000 Maryland consumers annually must secure strict opt-in consent before moving any patient information. This creates a severe architectural paradox. The state requires a live, centralized tracking system for addiction treatment, but aggressively penalizes the collection of the very health data needed to run it. Traditional healthcare software fails this new regulatory test because of how it processes searches. In a standard model, sending health information to a central server triggers immediate liability risk under new laws. To bypass this, Maryland Recovery Network built a zero PHI architecture. Instead of pulling data up, the server pushes the state's bed inventory down to the local browser. All the filtering happens locally on the client side. Not a single byte of patient health data ever travels back to the central server. By removing the data transmission, the platform instantly insulates the 406 Carillon and Medicaid accepting facilities currently in the network. The system operates strictly as a conduit for facility infrastructure data, the physical bed counts, rather than functioning as a repository for consumer health information. This client-side execution solves the privacy mandate. It creates a defensible regulatory moat that legacy competitors, burdened by central databases, cannot easily replicate. With the logistics and compliance layers resolved at the state level, the system targets the primary economic vulnerability for individual facility operators: revenue loss caused by intake drop-offs. Patients frequently abandon the admission process at the last possible moment. Surrendering autonomy to an unfamiliar medical institution triggers severe anxiety. The platform addresses this pre-admission friction through a visual intervention integrated directly into the intake workflow. This slide illustrates the integration of 360-degree virtual environments across 3 phases to eradicate intake friction. Here, we see the output on a mobile device. Patients can virtually walk the halls, inspect the cafeteria, and view group rooms in 360 degrees before packing a bag. Removing the blind spot of an unknown facility allows the patient to mentally prepare for the transition, effectively restoring a critical sense of agency. The operational return on this transparency is highly measurable. Listings equipped with these virtual tours generate 87% more profile views and achieve a 36% higher intake conversion rate. Eradicating the psychological friction of an intake is highly effective clinical empathy. It serves as the highest leverage economic mechanism to ensure beds stay filled. The clinical success of these visual assets directly powers the platform's overarching monetization strategy. The company utilizes a high-margin software-as-a-service model, with subscription tiers ranging from a $250 monthly baseline up to $2,500 premium integrations. To rapidly acquire facility inventory in high-need jurisdictions like the Baltimore region, they execute a founding partner go-to-market strategy. For a single upfront investment of $2,500, an operator secures the complete 360-degree virtual tour infrastructure across multiple properties, plus a priority listing in the regional search database. The integration extends to back-end administration as well. The platform automates mandatory Carillon workflows, instantly generating the 17-page prior authorization packs required for Medicaid admissions. Facility operators invest in the platform because it is an automated engine built specifically to eliminate empty beds. With the core infrastructure established, the platform's visual assets are positioned to scale into active therapeutic interventions. This diagram details the next step, pairing the software with $7.50 VR cardboard viewers. These low-cost viewers deliver immersive environments directly to patients, triggering specialized CPT medical billing codes that result in a projected annual return exceeding 2,100%. At the macro level, this platform functions as a statewide utility. It permanently resolves the ghost inventory crisis and fulfills the strict legislative requirements of Senate Bill 870. At the facility level, it leverages a zero-fi architecture and immersive virtual assets to conquer patient intake friction and strict ModPop privacy liabilities. By solving the underlying data logistics, Maryland's behavioral health system is shedding its blind directory model and evolving into a high-efficiency, fully connected dispatch infrastructure.